SDMCA Udupi, to take over the session. Welcome to you, sir. Sorry, sir, we are not able to hear you, sir.
Okay, now are you able to hear me?
Yes, sir. Yes.
Okay, now again we will start again from the commonest investigation which is done is about the hemoglobin, and to assess the hemoglobin you use a hemocytometer. If you go to the laboratory, you'll see that hemocytometer, and that hemocytometer, the principle is the hemoglobin is converted into hematine by adding a few drops of hydrochloric acid, and it is put in the central tube, and then you go on diluting it. Compare the color of the hematine to the standard colors which are present in the side tubes. And once the color becomes normal, and you assess like the hemoglobin, how much is the hemoglobin based upon the dilution which is added by the volume of the fluid. So basically it's about assessment of the color. So Anyavaranatham, assessment of the color is the basic issue. And once you have assessed the color, you will diagnose that the disease as the anemia if the hemoglobin is less than normal. And those are considered as the pandu roga. Of course, that's what we say. Now, how it is to be utilized clinically? If the hemoglobin level is 6 grams, then it's a non-viable. It's considered as non-viable, and you cannot just treat that condition with any of the medical treatment. You need to have a transfusion required. It has to be. If the oxygen carrying has to be continued, it has to be a transfusion required. If it is 6 to 8 grams without any other clinical emergency, then we can make use of what we call as Rakta Prasaraka medicines. And the principles of the treatment of Raktakshaya Upadrava mentioned in Sushruta. The Raktakshaya Upadrava mentioned in Sushruta is there will be Agni Mandya, and hence you will have to administer the treatment which improves the Agni as well as Anamla Swadu Aushadhis Aharas. Like, so the medicines we might use any of them. If it is above 8 grams but still less than the normal value, then you need to have a Brahmana therapy, which could be like what we call as the tonics. Like, now, this is a general approach to the treatment of Panduroga in general. Of course, more specificity, we will come to that specificity next as such. If there is a chronic anemia without identifiable blood loss, and then you may even treat that patient with the Shodhana therapy when the other real reasons are not really identified. A idiopathic anemia can be treated with the Shodhana therapy like either Virechana or Vamana, which can help significantly. But important is that it's not enough if you just confirm whether this is anemia or not. You need to go into the assessment of the cause of the anemia. So anyway, that's one of the examples of the color changes which are to be seen. Of course, the color changes also are the criteria by which you use the oxygen concentration. The pulse oximeter, which you see used in the clinics in the ward, uses the same phenomena of assessing the color. When Shushil has said, Tatra Arunaha Vatavaha Puryante Vayanasiraha, according to Sushruta, the flow of the contents in Vatavahasira or Pitavahasira or Kapavahasira, they are of different colors, and this, of course, people may not easily see that color changes when you open the blood vessel. But if you use a sensor with the color filter, the color changes can be assessed accurately, and exactly the same color changes principle is used to assess the oxygen concentration in the plasma. The pulse oximeter which you use will have a infrared wave passing through the fingers, and the filtered color which is red color, which is filtered, would be assessed as the hemoglobin concentration. Of course, if you use a red nail polish and then use the hemocytometer, there is a oxygen pulse oximeter, the concentration of the oxygen will be increased as per the oximeter, because it assesses the only color, the blind color as such. Anyway, that's about the color changes, varna. Now, when you say the anemia, it's not enough if you just see the color changes. There is a need to go further into the depth of it to assess those. And to do that, you go for the study of the smear, peripheral smear studies, cell studies. Now, studies of the cells of blood, it again has to have with the background information. The background information, the cells which are present in the blood are mainly of a myeloid series and lymphoid series. Myeloid series are those which originate from the blood bone marrow, and from the bone marrow, the cells which are originating. Whereas lymphoid are the cells which originate from the lymphoid system. Now, the cells which originate from the bone marrow, they are mainly from the bone marrow cells. We will have myeloblasts, it will be hemocytoblast, and hemocytoblast develops into a RBC, red blood cell. Or it can be myeloblast, which is developing into granulocytes, where you will have the WBCs, particularly basophil, eosinophil, and neutrophil. They are called as granulocytes because when you see under the microscope, the cytoplasm shows multiple granules of different colors. When these granules, they take eosin stain and hence look red in color. Now, when you use a hematoxylin and eosin stain, it takes the eosin stain and hence it looks red in color, and hence it's called eosinophils. This naming of these cells is based upon the affinity of the contents of the cells to the color. Eosinophils means those which take the eosin color and hence looks red. Basophils are those which take the basic stain of hematoxylin and hence they look bluish in color, and they are basophils. Neutrophils, where the granules are there but they don't take up both hematoxylin as well as eosin, and hence they do not show a significant red or blue color. Somewhat they will be showing a black, brownish color, where both the colors are almost uniformly taken in, and that's what we call as neutrophils. They are neutral to the color changes as such. Eosin is acidic stain, baso is hematoxylin is a basic stain, and hence they also are called as acidophils many times. Anyway, the important point is we may say that it's all advanced study of cells and then the nomenclature. The nomenclature itself is based upon the issue of the colors, varna. And the primary differentiation between the red blood cells and white blood cells, also when you say red and the white, it's again the color which is the identification factor. Lymphoid cells are those which originate from the lymphoid system, and they are presented as lymphoblasts, and then of course you will have either B lymphocytes or T lymphocytes. The ones which we see in the peripheral smear mainly are the B lymphocytes and the killer cells as such. Now, that's about the in general, very brief about the span of blood cells which you see. Now, when you study a peripheral smear, and usually we use hematoxylin eosin stain, the abnormalities of these stains could be when the RBCs which are present in the smear, they take lesser stain and their size is smaller. It's usually due to the deficiency of iron. If the iron is deficient, then the RBCs would have a lesser color. The hemoglobin concentration in the RBC would be lesser. We will have more discussion on this hemoglobin concentration and hemoglobin volume and this volume of the cells, etc. Now, when you see a smear, you can make out the size of the RBCs. RBCs usually, a mature RBC would have a 5 micron diameter as such. Whereas the cells which are deficient with iron, their diameter would be smaller, and hence they are called as microcytic. And because the hemoglobin concentration in the RBC is lesser, they are called as hypochromic. So when it is a microcytic hypochromic anemia, the appearance, it's confirmed that there is a deficiency of the iron. Now, deficiency of the iron could be due to two reasons. If there is a lesser supply of iron, or it could be more loss of iron. Lesser supply of iron can occur due to a real deficiency in the diet or a abnormal mechanism of absorption of the iron. Now, if you look at the patients with iron deficiency anemia patients in the clinical practice, large majority of the patients would have some abnormality with the metabolism of iron, the absorption and metabolism of the iron, than really the deficiency. A good, of course, another set of the patients whom we'll see is patients with the chronic blood loss like hemorrhoids or peptic ulcers, cancers, etc. In those conditions, the blood loss could occur. So when you look at the microcytic hypochromic anemia in the clinical practice, majority of the patients would have the features of some abnormality related to the iron absorption. The iron absorption itself is a complex mechanism, which I think we will not go into that. But the important is, of course, one of the important issue is iron. Even if you provide any large amount of iron directly, it may not be absorbed if the iron carrying protein, the apoferritin, is deficient in the plasma. And apoferritin is a proteinous enzyme which is necessary for binding the iron. Now, if this mechanism is deficient, then you will have a microcytic hypochromic anemia. And that microcytic hypochromic anemia, where the color looks pale, is actually the Vataja pandu. Vataja pandu mentioned in Samhitas. And of course, it also has the Vataja pandu. The basic issue is there will be the impact, this exaggeration of white color. Shukla Varna is exaggerated. Of course, Sushruta says even Shukla Siravanadham, the Shukla Sira is seen. We may not be able to see that. We may not be able to look at that. But with the investigations of the smear study, that Shukla color can be made out. Of course, treatment also in such conditions, a Kafagna Aushadis like Punarnamandura, Ashwagandharista are preferred as the treatment. Now, hemolytic anemia is the other way, where the RBCs could be destroyed and hence the patient may be anemic. Now, in these hemolytic anemias, one of the common causes of the hemolysis could be autoimmune reactions, like when a blood transfusion is done and then there could be a destruction of the RBCs. Or destruction of the RBCs also can occur due to organisms, pathological organisms, like malaria. Malarial parasites also can induce hemolysis. Now, other than that, now those are the specific diseases which are totally different from what we call as a hemolytic anemia conditions. When you say hemolytic anemia, it's due to the abnormality of the cells, the shapes of the cells, like either that should be the sickle cells. Sickle cells could be, now as you see in these smears, the sickle cells, or it could be the thickened layers, thickened RBCs. Hence, they get destroyed rapidly as these RBCs pass through the sinuses of the spleen, and they tend to get destroyed prematurely. That premature destruction of the RBCs results in accumulation of the bilirubin, and hence the patient would be having jaundice. So hemolytic anemia is usually accompanied with increased level of bilirubin, which results in pitakshanam, pita siravanadham, tadvarna vinmutrana khananka, a yellowish discoloration or icterus is seen. Now, once you have made the diagnosis, of course, I don't say that there will be a complete curable treatment for the sickle cell anemia or the spherocytosis where there is a genetic pathology, but other varieties of the hemolysis, they can be definitely managed on the line of the Pittaja Vyadhi, and my treatment usually would be Aragyavardhini Kumaryasa. Now, the megaloblastic anemia is another variety of the anemia where you will see the RBCs which fail to mature. There will be an abnormality of the maturity of the RBCs. RBCs shape will be bigger, the size will be bigger because the size diameter of the RBCs goes up to 8 to 10 microns. They are called as a megaloblastic anemia. And in that megaloblastic anemia, the clinical symptoms usually are, because there is an abnormality of the secretion of the acid from the stomach. So in the megaloblastic anemia, the primary pathology is in the stomach. and hence the absorption of the vitamins would be affected, and hence there will be GI symptoms, vague GI symptoms like patient would have flatulence, impaired appetite, or even occasionally loose stools, etc. And the patients also would have signs of peripheral neuropathy, like tingling sensation, which is typically of the Vata Vriddhi Lakshanas. Of course, Sushruta has given the description like there will be Krishna Siravanata, though the black coloration may not be seen practically with our naked eye, you will see the Vata Upadrava, Tata Annehi Tadu Upadravesha. The Vata Upadrava can be seen, Vata Upadrava like tingling sensation can be seen. And in these conditions, the usual treatment which I prefer would be Vata Shamaka Chikitsa, Chandraprabha, Ashwagandha Reste. This is a usual treatment. Now, when I say this usual treatment, it doesn't mean that every condition can be cured. It depends upon a further issue with the real cause of the pathology. Now, aplastic anemia is another variety of the anemia where there is a abnormality or failure of the growth of the RBCs. Bone marrow is not able to produce the RBCs in sufficient number. The pathology is primarily in the bone marrow. Causes again could be many. There could be many irreversible causes or reversible causes. Reversible causes like a chemical injury, drug-induced anemia, aplastic anemia. Like tetracyclines, they are well known to produce the aplastic condition. So in such conditions, the conditions may be reversible. If you stop those drugs, the patient may recover. Whereas irreversible conditions like leukemias, where the bone marrow may have a tumor pathology and hence is not able to produce that, then the prognosis may be totally different. Now, in the aplastic anemia, clinical conditions presentation would be, in addition to the pallor which is seen, there will be the systemic symptoms like susceptibility to infections. Most of the patients of aplastic anemia, they are diagnosed not because of the pallor, but because of a sustained infective symptoms like cough, or maybe at times it could be pus producing lesion somewhere, so on. So, and the prognosis in general is poorer. Of course, the prognosis could be better if you know the real causes as such. Now, that's about the aplastic anemia as such, which is considered by Sushruta as the Tridoshaja pandu. Tridoshaja pandu, where you will have the clinical symptoms like Jwara, Arochakra, Lhasa, etc. The systemic symptoms which are more common as such. I don't suggest any specific treatment for the aplastic anemia. Usually, patients where there is a irreversible pathology, you do not have a choice of other treatment than either the bone blood transfusion repeatedly or the bone marrow transplantation could be the choice. Reversible pathologies, if you know identify the real cause and if you can stop that, then of course the patients can recover. So comparatively, the issue is having more complicated issues as such. Now, another variation in this cell count, or what we see in the peripheral smear, is in case of polycythemia conditions. Polycythemia is a condition where the hemoglobin concentration in the blood is increased. Now, when we say hemoglobin concentration, later we will come to that, the mean corpuscular hemoglobin and hemoglobin concentration as such. Hemoglobin concentration is the amount of the hemoglobin present in the plasma per unit, or hematocrit. RBCs, total number of RBCs divided by the hematocrit is the mean corpuscular hemoglobin concentration. And in polycythemia, that hemoglobin concentration is increased. As the hemoglobin concentration is increased, as well as the number of RBCs is increased, the viscosity of the blood will be more. The blood becomes thicker, and hence there is a tendency for clotting. So polycythemia is identified clinically by the clinical signs of clotting anywhere. It could be clotting in the periphery, and hence the peripheral vessels may get clotted. And then you will have the features of either venous stasis or arterial insufficiency, or it could be clotting in any other central vessels like the cerebral vessels, and hence the patient may have a stroke-like symptom, or it could be cardiac pathologies, etc. If you remember, last year we had a patient of polycythemia and hence presenting with the features of the stroke, and the patient was treated with repeated bloodletting, the venipuncture. Now, anyway, that assessment of the polycythemia can also be done by the peripheral smear study where the cell number of RBCs can be seen to be increased and their color also would be increased. This I would consider as the Vatarakta, the features of Gambhira Vatarakta, where you will have the typical features of the discoloration, Shavaha, Tamraha, Daha, Todas, Purana, Pakavan. And the treatment will be on the line of Vatarakta, which you have seen already. Now, some more of the variations could be erythroleukemias. Leukemias of the peripheral smear is one more condition, where again the number of cells could be increased as well as the morphology of the RB cells would be altered. When the morphology of RBCs is altered and RBCs have that malignant changes, they are called as erythroleukemia, which is named as a Lagharaka. In the Lagharaka, which is a asadhya condition, according to Sushruta, the clinical presentation will be of Jvara Angamarda Brahmasada Tantra Kshaya Anvitaha. The systemic symptoms are the presentation. In all leukemias, it's exactly the same, like the clinical symptom will be of a reduced viability of the patient. Patient would have features like low grade fever or weight loss, anemia, and susceptibility to the infections. Then only the leukemias are diagnosed. Now, leukemias also could be of different varieties. Either it could be the erythroleukemia, or leukemias could be also be named as based upon the type of the cell involved, either as lymphocytic leukemia or lymphoblastic leukemia or myeloid leukemia. All of them have to be differentiated, and all these are the typical features of the cells being having some abnormal shape. Swabhava siddhanam sharira ekadeshanam anya bhavitvam. The basic character of these cells are, these cells would have an abnormal shape and the abnormal number, and that's the anya bhavitva. Anya bhavitva is the features of these Lagharaka, and all these I would consider as Lagharaka, and of course all of them would have a poor prognosis, and the value of a further detailed assessment is absolutely necessary. So each of these leukemia, they need to be assessed further, and depending upon the prognosis which is seen with the current therapies, it has to be advised. Most of the leukemias, majority of the leukemias, they are now curable with the current chemotherapy, and hence it's always better to direct the patient to have the current chemotherapy than what we can manage. When it reaches to an incurable state, now that's the other point, like how to assess that, that's a different issue. But if you assess that the condition is incurable and there is no choice in the contemporary system, then we may treat with our treatment as such. That's one thing. Now, the next point which we study under the peripheral smear is based upon the morphology of the cells, we study the shift. Now, to understand what we mean by shift, you need to know about the pattern of the growth of the cells. Now, in case of the WBCs, white blood cells which they grow, the white blood cells, they originate from the myelocytes which are present in the bone marrow, and they are bigger, around 20 microns in diameter, and the nucleus is almost occupying the whole cell. So a myelocyte is identified by its shape, the size, as well as the shape of the nucleus. And it becomes a metamyelocyte as it grows further. Gradually, the nucleus shrinks and the area of the cytoplasm increases. And as it matures, the nucleus gradually gets curved and lobulated, and the number of lobes in the WB, particularly neutrophils. Now, this is very true about the neutrophils. When you count the number of lobules in the nucleus, you can predict the age of the WBCs. On an average, a mature WBC would have 2 to 3 lobes. This is what we call as the medium age or the normal feature. But when the WBC becomes older, a older WBC retained in the plasma would have much more of these lobes as such. So when a WBC with more than 5 or 6 lobes as such nucleus, the lobes of the nucleus are seen, then we say that there is a hypermature or WBC remaining in the circulation. When you have more of WBCs present with the lesser lobes, like lesser than 2 lobes, or the WBCs with the intact nucleus, globular nucleus or coma-shaped nuclei, then we say that there is a immature WBCs coming through. Now, when you have more of immature WBCs, we say that there is a shift of the left. When there is more of hypermature WBCs, we say that it's a shift to the right. A similar issue also, similar word is used even in case of the RBCs. Now, first we discuss about the WBCs. Now, when there is a rapid destruction of the WBCs, the body tries to produce more of the WBCs, and hence you will have more immature cells or premature cells being released. Of course, the other way, where the WBCs are not destroyed and hence hypermature RBCs, WBCs may remain, they are not clinically very significant. Of course, in certain conditions where the patient may have undergone splenectomy, you may see this situation too, but clinically more important are the shift to the left. And whenever there is a shift to the left, what you see is in the peripheral smear. Peripheral smear, you will see multiple WBCs with either myelocyte stage or metamyelocyte stage. Metamyelocyte stage where the nucleus of the WBC still is not lobulated. Very few of the lobulated WBCs, even though the lobulation could be lesser, only 2 lobes as such. The WBCs with 4 or 5 lobes are virtually not seen in the smear. Then we say that there is a significant shift to the left. So the diagnosis is there is an increased destruction of the WBCs. Increased destruction of the WBCs can occur in many conditions. The most common condition could be infective pathologies, particularly in case of the typhoid. So in enteric fever, when the total leukocyte count also is reduced and there is an attempt by the body to push in more of the WBCs, you will have this kind of shift. A typhoid patient with a shift to the left will have a more severe prognosis, poorer prognosis. So this is how it is studied and it's helpful as such. Now, in case of the RBCs, also a similar shift mechanism is important. The RBCs, they originate from the hemocytoblast. Characteristically, hemocytoblast is of irregular shape and the diameter is around 20 microns, and the cell's nucleus will be present in almost occupies more than 3/4 of the shape. Then it gradually becomes a proerythrocytic stage. Normally, up to the proerythrocytic stage, the development occurs in the bone marrow, and hence you will not have the cells in the periphery as such. Peripheral smear, generally, proerythrocyte is not seen. But as it releases to the circulation, normally you will have large number of the erythrocytes released to the circulation, but before they develop into erythrocyte, there is a gradual reduction in the size and gradual reduction in size, as well as the number of or amount of the nucleus also will be reduced, and the number of the nucleus, size of the nucleus will be reduced, and you will have a stage where nucleus is represented by simply a network-like substance, and that stage is called as reticulocyte. Now, in the usual peripheral smear, you will have the mature erythrocytes, which are biconcave shaped discs, and their diameter is just 5 microns. Important is RBCs mature from a 20 micron size diameter to 5 micron size diameter. So growth in RBC means reduction of the size as such. Usually I crack a joke like everywhere when we speak of growth, the growth means increase in the size. In case of the RBCs, fibroblasts and intellectual quotient of Ayurvedic college students, growth means reduction. This is the usual joke, of course. The size gets reduced, and that's what we call as the growth asset. So a properly grown RBC would have a gradual reduction in size, and usually in the peripheral smear, you will see large number of these mature erythrocytes, which are biconcave shaped discs with the 5 micron size, or very occasionally a few reticulocytes. These other premature cells, they are not normally seen in case of the peripheral smear. Now again, it's the same, like if there is an increased destruction of the RBC, then there will be a shift to the left. You will have more of these premature cells. When more reticulocytes are seen, or even more of the hemocytes, different stages of the hemocytes are seen, then we say that there is a marked shift to the left, which suggests that the RBCs are being destroyed. Whereas if the RBCs are not destroyed and hypermature RBCs are remaining in the circulation, then their shape will be altered. They will have a central pale area, and their shape will be, instead of circular, their shape will be irregular. So the older RBCs, they are also called as Howell Jolly bodies. You will have a condensation of the material in the center. Hemoglobin, it becomes, it's not nucleus formed, but the hemoglobin condenses in the center, and hence you will have a central patch in these cells, and these are suggestive of RBCs remaining in the body without being destroyed. Usually a situation seen after splenectomy. Of course, clinically the significance is lesser, but post-splenectomy, patients after splenectomy, if you examine the peripheral smear, you can see these abnormal cells which are called as Howell Jolly bodies. So anyway, shift of the cells also is the feature, or rather the life cycle of the cells would be helping you to make the diagnosis. So that's all the point. That's exactly what Sushruta has mentioned as a apadana dharminam padana dharmitvam, padana dharminam apadana dharmitvam. The padana dharma is the life cycle, the natural death which occurs, and those which are not supposed to die, if they die prematurely, or those which are supposed to live for a longer time, and those which are supposed not to die and they die earlier. That's the features which are observed, and those features, padana dharma and apadana dharma, they are studied by more sophisticated tools of assessing the shapes of the cells, and hence we say it's as a shift to axis shift as left or the right. Now, this also can be the same pattern of the cells. Also, we may see as the red cell distribution width. Now, when you send a investigation for a hemogram, you may not really see the smear, but these abnormal cells could be counted with a counter, and you may get a graph. When you refer a patient for a hemogram, and in the hemogram reports, you may get a graph. And that graph gives you the idea of particular RBCs and their distribution width, like how many of the premature RBCs are seen, how many of the overmature RBCs are seen, and depending upon that, you get a standard called as the red cell distribution width. Red cell distribution width in the normal situation is around 12.6%. 12.6% in the sense you will have a few number of premature and a few number of the overmature RBCs, whereas in those patients who have an abnormal mechanism of production of the RBCs, particularly abnormalities related to the generation of the RBCs, you will have a wider RDW, or when there is a percentage is increased more than 12, 16 or more than that, then we say that there is an abnormality of the RBC. So when you, instead of looking at the microscope and making out, see that when you look at the microscope and make out, there is a possibility of making some errors. So now, most of the times, the shift of these cells is studied by assessment of the red distribution, RDW, that's red cell distribution width, seen under the hemogram studies. The hemogram studies is instead of making this at a microscope and direct viewing, you use a computerized counter. So number of the abnormal RBCs are made out as such. Now, the other hemogram, with all these microscopic features, like you will always have some possibility of error because the assessment is based upon what you see. To reduce that, the hemogram technique is used. In the hemogram technique, the same features which we have discussed, same factors which we have discussed, they are presented in a different terminology and different manner. And those parameters which you see a hemogram, one of the other parameter is MCV, or mean corpuscular volume. Of course, when you refer a patient for the hemogram, the first set of the features you see would be the hemoglobin concentration, then the counts of the cells. Counts of the cells, of course, it's the same. Then comes these features like the RDW, MCV, and MCHC, and so on. Now, what we mean by MCV, or mean corpuscular volume, is the total volume of the RBCs. Now, when we have seen under the microscope, we have discussed like a microcytic anemia and macrocytic anemia. Microcytic anemia, where the RBCs are smaller and the macrocytic where the RBCs are bigger. Now, instead of looking at the size under the microscope, which can create an error, the computerized data of hemogram studies, it will give you a volume of the total RBCs present as such. Total packed RBCs divided by the number of the RBCs gives you the MCV, and that mean corpuscular volume normal is in between 80 to 100 FL, whereas when it is less than 80, it suggests that the volume is volume of the RBC is lesser, macrocytic. When it is more than 100, then it's considered as the volume is bigger, there is a macrocytic. So now, majority of the situations, we may not go for the peripheral smear study in regularly every patient. Instead, we refer the patient for a hemogram. And whatever we see under the microscope, they are the same observations. They are given in a different language, and the interpretation is the same. So, volume of the RBCs is studied, which gives you an indirect interpretation about the size of the RBCs. Or similarly, the corpus hemoglobin concentration. Now, again, when we say hyperchromic and hypochromic, it's about the evidence of the color which you see under the microscope. Now, instead of that, if you make use of this technology and then assess the color, that again, in case of the hemogram assessment tool, that instrument which you use in the laboratory, if you go to the laboratory, you'll see that hemogram assessment tool, where there will be a sensor also, there will be a red light passing through, and that will assess the color. And it will assess the hemoglobin as well as the RBC number. So it's calculated by hemoglobin concentration multiplied by 10 divided by the number of RBCs, mean corpuscular hemoglobin as such. So mean corpuscular hemoglobin in a normal situation, it will be 27 to 31 as such. That's the usual. When the mean corpuscular hemoglobin concentration is more, it becomes hyperchromic, then it's the level is more than 31. And in hypochromic, like iron deficiency anemia, it will be less than 27. In erythrocytosis, etc., or polycythemia-like conditions, this is on the higher side, and iron anemia is less than iron deficiency anemia is less than 27 as such. This is how it is assessed. Or similarly, another variation is a mean corpuscular hemoglobin concentration. Now, mean corpuscular hemoglobin concentration gives you a combined impression about the volume of the RBCs as well as the hemoglobin concentration. So if the RBCs are lesser in number as well as their concentration of the hemoglobin is lesser, hypochromic lesser, and their size also is lesser, the color also is lesser, size also is lesser, naturally the hemoglobin concentration is much lesser. Whereas in case of the spirochetes or sickle cell conditions, the number may be smaller, size may be smaller, but the color, the density of the hemoglobin there will be more. So to make out that difference between the conditions, mean corpuscular hemoglobin concentration or MCHC also is used as such, where the concentration of the hemoglobin can be assessed, and the normal is 30 to 36. When it is more than 36, that means there is an abnormal hemoglobin present, like HBS or so on. The fetal hemoglobin, abnormal fetal hemoglobin, as in case of spirocytosis, thalassemia, sickle cell conditions, MCHC is raised, whereas iron deficiency anemia, it's usually MCHC is lesser. So the same interpretation which we study under the microscope, they are now studied with the hemogram studies as such. Now, another of the issue is what you study under the microscope would be the platelet count. With the platelets, one of the major problem with the microscopic study is that most of the times, by the time you prepare the smear, the platelets may get destroyed, and hence they are not very reliable. Hence, more reliable means of counting the platelet now is making use of these computerized counter. Before the computer counters were available, we used to depend upon only the microscopic picture, but microscopic picture of the thrombocyte studies would be always erratic. Now, the normal range is the 150 to 450,000, which you know as such. Now, platelet distribution would be, again, you will get this information under the this hemogram as such. the normal platelet volume, mean platelet volume, MPV, is 8.9 to 11.8, whereas the platelet distribution width, as we see in the RBCs, the distribution width, RDW, similarly, you will have a PDW, platelet distribution width, where the same information, like the growth and the status of the platelets, can be made out. If that's a platelet deficiency, in case of the thrombocytopenia, if it is lesser than 1,50,000, then we say thrombocytopenia. And occasionally you may have a thrombocytosis. The platelet count may be more than normal, which could occur due to the most of the times it's the transient causes like acute blood loss, or when the patients are recovering from thrombocytopenia and you are treating the patients. In patients of acute infections, it can increase as such. So that's about one thing. Last point in the smear, the blood smear studies would be the abnormal substances which could be present in the smear, which are not normally present. And those among them, the commonly is the parasites, particularly the malarial and the filarial, which are quite important from our clinical point of view. Now, when you look at the microscope and see under the microscope, the RBCs may show the presence of the different organisms. Now, particularly the falciparum, you may see the different stages, the ring stage, the trophozoite stage, schizons, or gametocytes. Most of the times when the patient would have a fulminant malaria, you will be able to see the gametocytes as well as the schizons. These are the commonly seen abnormalities within the RBCs. These grow within the RBCs. Of course, by just looking at the shape of these substances, these these artifacts, these are called as artifacts, we can conclude whether it is a falciparum or vivax. Falciparum, the ring will be a perfect ring, whereas in vivax it will be somewhat irregular shaped, somewhat star shaped. And schizon stage, vivax will have more dye accumulated. Gametocytes of the vivax would be somewhat globular in shape, whereas falciparum will be elongated. So based upon that, we will make the diagnosis based on what you see as the abnormalities of the RBC shape as. Similarly, the microfilarial smear would show the evidence of the filariae, the microfilariae, and commonest which we see in our area is Eryhroleukaemia bankrupti, and Eryhroleukaemia bankrupti would be having a basophilic character. It will take bluish stain and it will have a wider head and narrow tail. Whereas the Brugia malai, which is rare in our condition, but occasionally can be seen, particularly in Shomog area, Brugia is common, and there they will have a acidophilic stain, the eosin stain, reddish color, and they will these worms would have the multiple broken these cytoplasmic contents. They will have segmentations as such. Logolo, which is extremely rare in our area, will have both the ends, head as well as the tail, being very thin taper as such. So based upon these shapes, we will confirm like whether it is the filaria of which type of the filaria, that's type of nature of the filaria can be confirmed. When we study the peripheral smear for these parasites, the important is the smear has to be collected from the periphery only. So venous blood cannot be used. It has to be from the periphery. By pricking the tip of the finger or the earlobe, the blood has to be collected. And ideally, the blood has to be collected when the patient is febrile. These are the important basic conditions which are required, and by that you can make out. So that's about some of those information about the smear studies and their issues. I think we will conclude today, and the next we will continue with the colorimetry and spectrophotometry, the abnormalities of the color further. If there are any questions, I think. There are some questions like in pandu, anemia actually has been mentioned as a. I'm not able to make out. Why there will be amla preeti? That's the question. Like, see, that's a amla preeti is one of the clinical symptoms. Reasons, of course, it's quite difficult to make out. The major functions of the amla rasa would be to facilitate the rasa dhatu to be formation. So that could be the reason. And if we do go by Samanya Vruddhi Karana, Amla Dravyas has to be given. Anamla Dravyas, Sushruta has mentioned very clearly, Swadu Anamlehi. Anamla Dravya is suggested as the line of treatment in Sushruta for the treatment of Raktakshaya. That's the exact standard description. Then there is another question like, if HB is more than normal level, it has to be considered as a under Vatarakta. Yes, of course. I do consider this as Vatarakta because Vatarakta is characterized by Vruddhena Raktena. So Rakta Vruddhi is the feature. Where do we shift to the right in case of WBCs? WBCs right is often seen in patients with the reduced immunity, like HIV and so on. But clinically, the significance of right shift is less important than the left shift. Then which type of anemia we should use? Rakta Prasadaka. As I said, in case of iron deficiency anemia or the Kafaja Pandu Lakshanas. That's the usual preferred treatment which I usually use as such. Rakta Vardhaka is, of course, Rakta Prasadaka and Rakta Vardhaka, the differences are very negligible. There is no such specific description of Rakta Vardhaka in the text as such, in a Samhitas. Of course, later the Devaguna people, they have made it as Rakta Vardhaka and Rakta Prasadaka. So that's it. Then what is the maximum level of WBC we can consider as a Asadhya action? Of course, it may not be possible to make out Sadhya Asadhya based upon the number alone. You need to have more elaborate study to confirm whether it's a leukemic pathology or not. Leukemias, they may be considered as a Asadhya, whereas infective pathologies and hence the leukocytosis may be considered as Sadhya. As far as the infective conditions are concerned, when the count goes above 18,000, I usually prefer to treat that patient with the antibiotics, whereas if it is less than 18,000, we can manage with our medicine. This is one of the criteria which I have applied in my clinical practice as a safe measure, but there is no such standard rule which could be said as such. I think that's about the questions. Right. There are no more questions. Then there is another question. Clinically, when not to prefer patients when chemotherapy and prescribe our medicines. So of course, the main principle of dealing with the patients is when there is a definite curative treatment in the alternative system, contemporary system, and when we do not have such a very definite assured result with our treatment, I would always prefer the patient to go to the other system. If the other system also doesn't have a treatment and we also have some uncertainty, okay, fine. In that condition, taking a risk is justified. So in my treatment, I always consider the safety of the patient and to ensure that the patient is not deprived of the facilities of the contemporary development. So that's a very sensitive issue. The answers could be of different varieties by different people, but my answer is very clear. I ensure that the patient gets the best possible treatment. That's the point. Right? To go into more detail will be quite difficult. Right? So I think we can conclude now. It's time.
On behalf of everyone, I thank you, sir, for such an informative session.